Christine, a 20-hour-old female infant, presented with neonatal jaundice. She was born at term following an uncomplicated pregnancy. Physical examination shows she's alert, well perfused, feeding normally, and afebrile. The skin is yellow in the face, trunk, and limbs, but there's no organomegaly. Laboratory studies reveal high total bilirubin of 25 milligrams per deciliter, normal liver function tests, and no evidence of hemolysis. On the other hand, a 17-year-old boy named Steven comes to his primary care physician because his sister has been telling him that, periodically, he looks a little yellow. Medical history is non-contributory, physical examination shows no abnormalities, but Steven mentions that he recently started working out and dieting to prepare for prom. Laboratory studies show elevated total bilirubin concentration. A week later, his bilirubin concentration is normal. Now, both Christine and Steven have jaundice, but the underlying cause of their problem is different. Jaundice, also called icterus, is the abnormal yellowish pigmentation of the skin, mucous membranes, and sclera due to the deposition of bilirubin. The reference range for total bilirubin is 0.2 to 1.2 milligrams per deciliter, while jaundice typically occurs when total bilirubin levels exceed 2 milligrams per deciliter. Now, for your exam, it's crucial to know the metabolism of bilirubin. When old red blood cells pass through the spleen, macrophages eat them up and break down the hemoglobin to heme and globin. Heme is then converted into biliverdin by the enzyme heme oxygenase. Biliverdin is further converted into unconjugated or indirect bilirubin by the enzyme biliverdin reductase. Unconjugated bilirubin is the form of bilirubin that's lipid soluble. Since it's not water soluble, this form of bilirubin binds tightly to albumin in the blood. Therefore, it can't be filtered by the kidneys and excreted in the urine. Instead, the unconjugated bilirubin undergoes hepatic metabolism of bilirubin, which consists of three main phases. The first phase is carrier-mediated uptake of bilirubin at the sinusoidal membrane of the hepatocyte. In the second phase, two molecules of glucuronic acid are attached to bilirubin by an enzyme called UDP glucuronidase. The final product is bilirubin diglucuronide, which is also known as conjugated or direct bilirubin. In contrast to unconjugated bilirubin, conjugated bilirubin is water-soluble. So this form is secreted into the bile canaliculi, further drains into the bile ducts, and eventually into the gallbladder. Now, after a fatty meal, cholecystokinin causes contraction of the gallbladder, which squeezes out the bile into the biliary duct system and further through the ampulla of Vater into the duodenum. It's important to note that most of the bilirubin found in bile is in the form of conjugated bilirubin, but a small portion consists of unconjugated bilirubin. In the gut, intestinal microbes convert conjugated bilirubin to urobilinogen, or UBG. 80% of the urobilinogen is converted to stercobilinogen, which is further oxidized into stercobilin, which is responsible for the brown color of feces. On the flip side, 20% of urobilinogen gets reabsorbed into the blood and spontaneously oxidizes into urobilin. 90% of the urobilin is sent back to the liver, and 10% is excreted by the kidneys, and it's responsible for the yellow color of urine. Now, if there's a problem with bilirubin metabolism, bilirubin accumulates and hyperbilirubinemia occurs. And based on the form of the bilirubin that's elevated, hyperbilirubinemia can be predominantly unconjugated, conjugated, or mixed. Unconjugated or indirect hyperbilirubinemia is caused by an increased breakdown of hemoglobin, impaired hepatic bilirubin uptake, or defective conjugation of bilirubin. Increased breakdown of hemoglobin is commonly seen in intravascular hemolytic conditions such as hemolytic disease of the newborn, sickle cell anemia, and glucose 6 phosphate deficiency. Increased destruction of red blood cells results in increased breakdown of hemoglobin and eventual unconjugated hyperbilirubinemia. On the other hand, impaired hepatic bilirubin uptake can be caused by congestive heart failure or some medications, such as rifampicin and probenecid. Finally, defective conjugation of bilirubin can be physiologic, which is also referred to as physiologic jaundice of the newborn, or pathologic, which is commonly seen in hereditary conditions, such as Gilbert syndrome and Crigler-Najjar syndrome. Now, as mentioned before, unconjugated bilirubin is lipid soluble, meaning it can deposit in many organs of the body, including the brain. Deposition of unconjugated bilirubin in basal ganglia can cause bilirubin encephalopathy, also known as kernicterus, which is a potentially fatal condition characterized by jaundice and neurological problems. In addition, these individuals can have an increased concentration of unconjugated bilirubin in bile, and this can result in the formation of numerous small black pigmented gallstones. Now, physiologic jaundice of the newborn is extremely common, and this is especially the case for preterm infants. A high-yield fact to remember is that it typically manifests within the first 2 days to 1 week of life. It's important to note that physiologic jaundice of the newborn is more commonly seen in Asian newborns. At birth, newborns have a high hematocrit, but their red blood cells have a shorter life. As a result, when a large number of red blood cells turn over, a lot of unconjugated bilirubin gets released. To make this problem worse, newborn livers have immature UDP glucuronoltransferase. Therefore, they're inefficient at conjugating this bilirubin, and this eventually leads to unconjugated hyperbilirubinemia. It's important to note that sulfonamides and ceftriaxone should not be given to neonates and infants due to their ability to take up bilirubin binding sites on albumin, thereby exacerbating or facilitating jaundice. Usually, this is a totally benign condition, but kernicterus can occur when large amounts of unconjugated bilirubin starts to deposit within the brain, causing brain damage. Even though physiologic jaundice of the newborn typically resolves without treatment in 1 to 2 weeks, babies that require therapy are usually treated with non-UV phototherapy, which isomerizes unconjugated bilirubin to a water-soluble form that can be excreted by the body. Another type of jaundice that can be seen in healthy newborns is breast milk jaundice, or BMJ. The gut flora is established 1 to 2 years after birth, so when born, babies don't have enough bacteria to convert conjugated bilirubin to urobilinogen and eventually to stercobilin. With breast milk jaundice, high levels of glucuronidase in breast milk actually deconjugate conjugated intestinal bilirubin, thereby increasing enterohepatic circulation of unconjugated bilirubin, eventually causing unconjugated hyperbilirubinemia and jaundice. For your exam, you should know that breast milk jaundice develops after the first 5 to 7 days of life, and it peaks after 2 weeks. Now, it's important to differentiate breast milk jaundice from breastfeeding failure jaundice, or BFJ, which is also known as starvation jaundice. Breastfeeding failure jaundice typically occurs during the first week of life, and it's usually caused by decreased or poor intake of breast milk. As a result, these babies have inadequate stooling and decreased elimination of bilirubin by stool. Eventually, this leads to increased enterohepatic circulation, which is further followed by unconjugated hyperbilirubinemia and jaundice. Also, it's important to mention that breastfeeding failure jaundice is associated with clinical features such as suboptimal breastfeeding, mild dehydration, and weight loss in the first few days of life. Finally, treatment of breastfeeding jaundice includes prevention of dehydration, and increased frequency and duration of feeds, which promote excretion of bilirubin. Alright, now moving on to autosomal recessive conditions, Gilbert syndrome and Crigler-Najjar syndrome. Gilbert syndrome is a relatively common, benign genetic condition that's associated with an impaired hepatic bilirubin uptake and reduced production of the enzyme UDP glucuronidotransferase. In other words, these hepatocytes are less effective at conjugating bilirubin, and this can result in unconjugated hyperbilirubinemia. A high-yield fact is that individuals with Gilbert syndrome are typically asymptomatic, but they can also present with mild jaundice. This usually occurs in response to one of the classic triggers, which include fasting, febrile illness, fatigue, stress, and physical exertion, all of which induce mild hemolysis. Therefore, you should think of Gilbert syndrome in a person who presents with mild jaundice, no apparent liver disease, and normal liver function tests. On the other hand, Crigler-Najjar syndrome type 1 is characterized by the absence of UDP glucuronidotransferase. Therefore, individuals with this syndrome can't conjugate bilirubin at all. Ultimately, this leads to unconjugated hyperbilirubinemia with a very high total bilirubin that can range from 20 milligrams per deciliter up to 50 milligrams per deciliter. For your exam, you have to know that symptoms typically occur soon after birth, and these infants present with persistent neonatal jaundice and even kernicterus. On rare occasions, they can even develop neurological problems later in life. As far as treatment goes, individuals with Crigler-Najjar syndrome type 1 are treated with plasmapheresis and phototherapy. It's important to note that phototherapy does not conjugate bilirubin molecules. Instead, it works by increasing polarity and water solubility of unconjugated bilirubin. But since this condition is associated with a fatal outcome, the only curative treatment for individuals with this type of Crigler-Najjar syndrome is liver transplantation. On the flip side, Crigler-Najjar syndrome type 2 is the less severe form, and it's associated with reduced activity of the UDP glucuronidotransferase enzyme. As a result, these individuals develop unconjugated hyperbilirubinemia with total bilirubin that's usually below 20 milligrams per deciliter. Prognosis is good, since people with this type have a good response to treatment with phenobarbital, which induces the synthesis of liver enzymes. Now let's move on to conjugated or direct hyperbilirubinemia, which is commonly associated with pruritus or itchiness. Furthermore, you have to know that pruritus occurs due to increased plasma bile acids that build up in tissues. Now, conjugated hyperbilirubinemia can be caused by decreased excretion of bilirubin, some biliary tract conditions, and biliary tract obstructions. Decreased excretion of bilirubin is commonly seen in hereditary conditions, such as Dubin-Johnson syndrome and Rotor syndrome. Dubin-Johnson syndrome is a benign, rare genetic condition that's characterized by the absence of a biliary transport protein found on the canalicular membrane of the hepatocyte. This transport protein is called multi-drug resistance protein 2, or MRP2 for short. As a result, less conjugated bilirubin is transported out of the hepatocyte into bile canaliculi. Eventually, this leads to conjugated hyperbilirubinemia with total bilirubin levels between 2 and 5 milligrams per deciliter. But it's important to note that these individuals can also present with normal or extremely elevated levels of bilirubin that can range between 20 and 25 milligrams per deciliter. For your exam, you should know that most individuals are asymptomatic, while some have non-specific symptoms such as fatigue, abdominal pain, and weakness. In some cases, individuals present with mild jaundice that's usually noted during illnesses, pregnancy, or after using certain medications, like oral contraceptives. You should think of this syndrome in individuals who have elevated total bilirubin with the conjugated bilirubin fraction of at least 50% and normal liver function tests. The diagnosis is confirmed by detecting abnormally high levels of coproporphyrin 1 in urine. Histopathology reveals normal hepatocytes with a dense pigment composed of epinephrine metabolites within the lysosomes of hepatocytes. A frequently tested concept is that individuals with Dubin-Johnson syndrome have strikingly black livers. Since individuals with Dubin-Johnson syndrome have good prognoses, no treatment is necessary. Next, we have Rotor syndrome, which is another benign condition that's associated with numerous defects in proteins that enable normal hepatic uptake and excretion of bilirubin. The defective proteins lead to an accumulation of conjugated bilirubin and conjugated hyperbilirubinemia. Individuals with Rotor syndrome have total bilirubin levels below 5 milligrams per deciliter, and they can be asymptomatic or they can present with mild jaundice. In contrast to Dubin-Johnson syndrome, the urinary excretion of coproporphyrin 1 is normal, and the liver has a regular color. Finally, no specific treatment is required since these individuals enjoy normal life expectancies. Conjugated hyperbilirubinemia is also associated with biliary tract conditions such as primary sclerosing cholangitis and primary biliary cholangitis. Primary sclerosing cholangitis, or PSC, is a progressive liver disease characterized by inflammation, fibrosis, and strictures of both intra- and extrahepatic parts of the biliary tree. This is classically described as onion skin fibrosis because, on histology, it looks a bit like an onion skin, with concentric rings of fibrosis around the bile duct. It's classically seen in middle-aged males with inflammatory bowel disease. It's also linked to cholangiocarcinoma and cancer of the gallbladder. On the other hand, primary biliary cholangitis, or PBC, is associated with the gradual destruction of epithelial cells lining the intrahepatic biliary ducts by granulomatous inflammation. The cause is unknown, but it's possibly autoimmune in nature, since it's typically seen in middle-aged females with another autoimmune condition, like autoimmune thyroiditis or rheumatoid arthritis. Symptoms of primary biliary cholangitis develop gradually, first with pruritus, especially at night, and fatigue. As the condition progresses, these individuals present with signs of cholestasis, such as jaundice, pale stools, and dark urine. And since the liver plays a major role in cholesterol metabolism, PBC can lead to hypercholesterolemia, which can manifest as xanthelasmas. Xanthelasmas are a type of xanthomas, which are cholesterol deposits that present as well-demarcated yellow papules or plaques. Xanthelasmas typically occur on or around the eyelid. Finally, conjugated hyperbilirubinemia and jaundice can be caused by biliary tract obstruction. Also, don't forget that obstruction of the normal bile flow also leads to pale stools and dark urine. This is because there's less conjugated bilirubin in the intestines, so there's less urobilinogen and stercobilin, and this results in pale stools. On the other hand, increased levels of conjugated bilirubin in the blood lead to dark urine. Since there is less bile secreted into the intestines, individuals with biliary tract obstruction are commonly associated with hypercholesterolemia and malabsorption of fat-soluble vitamins, A, D, E, and K vitamins. As far as laboratory findings go, individuals with biliary tract obstruction typically present with elevated alkaline phosphatase and gamma-glutamyl transpeptidase. Now, biliary tract obstructions are usually caused by gallstones, and this happens with choledocholithiasis, which is the presence of a gallstone in the common bile duct, and acute cholangitis, which is an infection behind the blockage. For your exam, you absolutely have to know that the Charcot triad of cholangitis includes jaundice, fever, and right upper quadrant pain. Another cause is cholangiocarcinoma, which is a tumor of the bile ducts that can be either intrahepatic or extrahepatic. In addition, the normal flow of bile can be compromised by tumors outside of the biliary tree, such as liver and pancreatic cancer. Pancreatic cancer that's associated with jaundice is typically located in the pancreatic head or neck. Now, the most common pancreatic cancer is pancreatic adenocarcinoma, which arises from the epithelial cells lining the pancreatic ducts. This is a very aggressive tumor, and its histopathologic features include disorganized glandular and ductal structures with cellular infiltration. Important risk factors include smoking, high alcohol consumption, and chronic pancreatitis, especially if it lasts more than 20 years. Also, it's important to note that individuals older than 50 years of age and Jewish or African American males have a higher risk of developing pancreatic adenocarcinoma. Common clinical features include mid-epigastric pain that radiates to the mid or lower back, weight loss due to malabsorption and anorexia, and trusosine, also called migratory thrombophlebitis, which is when blood clots appear unexpectedly in superficial veins and then over time migrate to different locations. Another high yield point is that trusosine presents with swelling, erythema, and tenderness on the extremities. Also, these individuals can present with Courvoisier sign, which is an enlarged, palpable, and non-tender gallbladder, along with jaundice. It's important to note that at the time of presentation, these individuals typically have metastasis. Therefore, their average survival rate is 1 year after diagnosis. A frequently tested fact is that tumor markers associated with pancreatic adenocarcinoma are carbohydrate antigen 19-9, which is used for diagnosis and monitoring of pancreatic adenocarcinoma, and carcinoembryonic antigen, which is less specific since it's also seen in individuals with colorectal, breast, lung, and thyroid cancers. Finally, treatment of pancreatic adenocarcinoma includes the Whipple procedure, also known as pancreaticoduodenectomy, chemotherapy, and radiation therapy. And don't forget, individuals with lung cancer can have liver metastasis. Therefore, they can present with jaundice, just like the ones with liver or pancreatic cancer. Finally, for your exam, you have to know that Clonorchis sinensis is a liver fluke that's associated with obstructive jaundice. Similar to biliary tract obstruction, there's also biliary atresia, which occurs in infants. This is a childhood disorder where the gallbladder fails to form, or there's early fibroobliterative destruction of the extrahepatic biliary tree. It can be caused by inflammation of the biliary tract, typically due to viral infection or toxins. And by the end of the 3rd week after birth, there's a total obstruction of the biliary tree. For your exam, it's important to remember that neonates with biliary atresia have normal birth weight and weight gain, but you should suspect biliary atresia in neonates that present with persistent jaundice after 2 weeks of life, dark urine, acolic stools, and hepatomegaly. Physical examination shows firm and enlarged liver, while laboratory findings reveal increased levels of conjugated bilirubin, alkaline phosphatase, and gamma-glutamyl transferase. It's also important to note that the method of choice for the diagnosis is a liver biopsy, which shows intrahepatic bile duct proliferation, fibrosis and edema of the portal tract, and parenchymal cholestasis. Biliary atresia is the most frequent cause of early childhood death related to liver disease. Therefore, it requires surgical intervention to prevent progression to biliary cirrhosis. Finally, biliary atresia is the most common reason for pediatric liver transplantation. Now, a frequently tested concept on your exam is to differentiate unconjugated and conjugated hyperbilirubinemia, and an easy way to do this is by using urinalysis. In unconjugated hyperbilirubinemia, there is no problem with liver metabolism, so there is an increased production of conjugated bilirubin. This means that individuals with unconjugated hyperbilirubinemia have more urobilinogen in the intestines. More urobilinogen means more reabsorption and excretion by the kidneys. Therefore, these individuals have increased levels of urobilinogen in urine. But it's important to note that unconjugated bilirubin is not increased, since it's not water soluble. Therefore, it can't be excreted in the urine. On the other hand, in conjugated hyperbilirubinemia, low amounts of conjugated bilirubin reach the intestines. Therefore, there's less urobilinogen in the intestines, means less reabsorption and excretion by the kidneys, so the amount of urobilinogen in the urine is low. Last but not least, mixed unconjugated and conjugated hyperbilirubinemia is typically caused by hepatocellular problems due to impaired bilirubin conjugation and canalicular excretion. This type of hyperbilirubinemia is commonly seen in individuals with hepatitis and cirrhosis. Alright, as a quick recap, jaundice is the abnormal yellowish pigmentation of the skin, mucous membranes, and sclera due to the deposition of bilirubin. It typically occurs when total bilirubin levels exceed 2 milligrams per deciliter and can be caused by an increased breakdown of hemoglobin, impaired hepatic bilirubin uptake, and defective conjugation of bilirubin. Unconjugated or indirect hyperbilirubinemia can be physiologic or pathologic. In severe cases, unconjugated bilirubin can accumulate in the brain, causing bilirubin encephalopathy, which is also known as kernicterus. Physiologic defective conjugation of bilirubin is also known as physiologic jaundice of the newborn, and it's due to immature UDP glucuronoltransferase. On the other hand, pathologic defective conjugation of bilirubin is commonly seen in Gilbert syndrome, which is associated with impaired hepatic bilirubin uptake and reduced production of the enzyme UDP glucuronoltransferase, and Crigler-Najjar syndrome, which is characterized by the absence or reduced activity of UDP glucuronoltransferase. Conjugated or direct hyperbilirubinemia is caused by decreased excretion of bilirubin, which is commonly seen in Dubin-Johnson syndrome, which is characterized by the absence of a biliary transport protein found on the canalicular membrane of the hepatocyte, and Rotor syndrome, which is associated with defects in the protein that enable normal hepatic uptake and excretion of bilirubin. Other causes of conjugated or direct hyperbilirubinemia include biliary tract conditions such as primary sclerosing cholangitis and primary biliary cholangitis, but also biliary tract obstruction, which can be caused by gallstones, cholangiocarcinoma, liver flukes, liver and pancreatic cancer, and biliary atresia. Finally, mixed unconjugated and conjugated hyperbilirubinemia is common in individuals with hepatitis or cirrhosis. Now let's go back to our case. Christine is a 20-hour-old female infant with neonatal jaundice but without organomegaly. Laboratory studies revealed a total bilirubin of 25 milligrams per deciliter, normal liver function tests, and no evidence of hemolysis. There are many potential causes for neonatal jaundice, like breast milk jaundice or physiological jaundice. The key clue here is the extremely elevated total bilirubin level, which is more common in Crigler-Najjar syndrome type 1, where there is a complete absence of functional UDP glucuronoltransferase. So these individuals can't conjugate bilirubin at all. Also, they're at risk of developing kernicterus, so they must be treated timely with plasmapheresis and phototherapy. Remember that phenobarbital does not treat this disorder, since it works by inducing the production of liver enzymes. On the other hand, Stephen is a 17-year-old boy who came to his primary care physician because his sister had been telling him that he looks a little yellow sometimes. Medical history was non-contributory. Physical examination showed no abnormalities. Liver function tests were normal. One of the laboratory studies revealed elevated bilirubin concentration, but a week later, his bilirubin was back within normal range. Stephen most likely has Gilbert syndrome, where there is an impaired hepatic bilirubin uptake and reduced production of enzyme UDP glucuronoltransferase. So when there's a stressor that causes increased hemolysis, like the combination of dieting and increased exercise, this can cause mild jaundice and temporary elevation in bilirubin. No treatment was necessary, but Stephen was advised to eat regularly and avoid fasting.